So, Dr. Procyshyn, we have known each other a long time now. I moved to Vancouver in 2004, and I think I probably met you that year or the next year, but it wasn't until 2011 that we met. And I actually can remember where we met and talked first about what became SwitchRx. Do you remember that?
I remember the year 2011. I remember picking up the phone and you saying, what are you going to be doing for the next 20 years of your life? But I don't remember where.
I don't think you remember that because we met in person. We were at a meeting, a conference, and I said to you, aripiprazole had come on the market, and I said, I'm hearing all the time that aripiprazole causes insomnia, and I don't think it causes insomnia. What I think causes insomnia is the fact that they're stopping quetiapine or they're stopping olanzapine. They're not thinking about the drug the patient is on. And of course, when you have side effects, you always blame the new drug. So we had that conversation and I said, what do you think about trying to create a website that helps people not just to think about the new drug, but also to think about the old drug and what you have to be aware of as you're doing a switch?
I do remember the conversation. I do remember adding to it that I was given many lectures around aripiprazole at that time. And it was the partial agonist, the partial D2 receptor agonist. And I would be given lectures and physicians, says, I'm not using it. I don't use it. It doesn't work. And I kept hearing that over and over again. And I started to think more about that. And then I realized it's not that it doesn't work. And I said, let me tell you about the patient that you're switching to aripiprazole. Those patients had been previously on antipsychotics. You were D2 blocking them for many years. And then all of a sudden you thought you could just stop it and start a partial agonist. And then the lights started to turn on. So I do remember that conversation, and we decided and we thought, well, what a great opportunity to help physicians when switching medications.
It's so funny because your response there, it captures the essence of Ric and the difference between Diane and Ric. Because I say, completely clinically, I heard people are complaining that aripiprazole causes insomnia, and so they're not switching properly. And your mind always goes to, as the professor, all of the underlying mechanisms that make it not work. And it doesn't work for a whole bunch of reasons. And that's what SwitchRx was for. It was actually to highlight all of the pharmacology of these medications when you're trying to switch so that you help the patient have a better path to getting on a new and hopefully better tolerated medication. So, Ric, I'm so very proud of the work that we have done because, and a lot of people might not know this, but we have almost 140,000 people, clinicians, and that could be psychiatrists, researchers, pharmacists, nurse practitioners, family practitioners who have used SwitchRx. We have probably about 1,500 to 2,000 switches every day, uses of SwitchRx, and we have more than 100 clinicians every day signing up. And that speaks to the work that we've done and the trust that we've garnered through SwitchRx over these last 15 years.
So I'm going to date myself here, but going back to the 1990s when I was doing my psychopharmacology residency at Riverview Hospital, it was my impression that psychiatrists at the time were prescribing based on their clinical experience with a psychotropic medication, not necessarily based on the pharmacology, the pharmacodynamics, or the pharmacokinetics. And part of that likely was because there wasn't a lot of information at the time. My goal in my residency was to fully understand receptor pharmacology, receptor pharmacodynamics, and kinetics. And that actually really helped me to understand the pathophysiology of these illnesses. It helped me to understand better how to treat these illnesses. It helped me to predict side effects of these medications, but it also helped me to think about how to switch between psychotropic medications. So again, that goes a long time back. And then in 2011, many, many years later, you approached me with this idea of, hey, let's make a switch site.
I think that's really the secret sauce is we're trying to marry the psychopharmacology, the pharmacokinetics with the clinical lens of how do these drugs work in a clinician's hands? How do patients experience them?
Yeah, and I'm always reminded, too, that you have mentioned before, and rightfully so, that sometimes receptor pharmacology does not match clinical outcomes. But, when I think of it again more as a scientist and I think about receptors, I'm thinking, well, at least it's given us some guidance as to what we might be seeing. And this is what we do put onto SwitchRx. We do give them some ideas of what they might expect when they're doing a particular switch. But again, I'm mindful that sometimes receptor pharmacology doesn't always translate clinically.
It's such a great point, and I have so much fun when we're working together in various things where you point out, well, this could do this and this could do that, and it could. And every patient is such an individual, right? That I never say never. If I see a side effect, I don't say, oh, that drug doesn't cause that. I think, well, maybe in you it does. But when you're saying, this receptor could cause this or this drug may cause this because it's tickling this receptor, I always think, have I seen that? Is that what I see clinically? And I think, again, that's some of the secret sauce we have is looking at it from different perspectives, bringing the science in, but also thinking about the clinical outcomes, the clinical experience of the patient as well. Are they having those side effects? And how do we mitigate those side effects? Thinking, again, about receptors.
And again, I think that's some of the richness of SwitchRx for both the physician and for the patients. So the physicians can see and predict based on SwitchRx, these are the side effects that my patient may experience. I should monitor for them. But also to tell my patient, watch for this. And also, too, SwitchRx is nice. It's got a graph. You can show the patient the graph. In your particular case, we may start to increase the dose of a medication while we taper down a medication. In another patient, it might be we're going to maintain the dose of the first medication before we take down the second medication. So it's a very useful tool, not just for physicians, but also for patients.
So there's a reason, Ric, why we have almost 140,000 users over all of these years is because drug companies have not typically done switching studies. It's not really to their benefit a lot of the time. So we don't have a lot of science to look at as far as empirical research that says this is how you do a switch or this is why a switch works, because companies tend not to do that. So what we did was say, okay, how did these drugs work? How will they work together? And so we're actually creating that experience based on the pharmacology, because we can't go out and search a paper that tells you how to do that. People just didn't do those studies.
And that reminds me too, when you think about clinical trials done in the past where they've taken somebody off a medication and they started them on another medication, and the outcome is some of these patients get better and some of them don't. And you have to wonder, back when they weren't thinking about switching and the problems that could be encountered during a switch, how well were these clinical trials done? Because probably the outcomes were minimized, and maybe the outcomes could have been better if they had a better switching approach.
Well, let's remember that back in the day when the antipsychotics, the newer atypical antipsychotics came online, so think about olanzapine, it never caused weight gain. Paxil never caused sexual dysfunction. Funny that, isn't it? We know now that they weren't asking the questions. They weren't monitoring those things. They weren't looking over time. So we know that those SSRIs, most of them have terrible problems with sexual dysfunction. Now studies use ASEX. They use scales that actually assess sexual dysfunction. But back when we started, we didn't know about these. We discovered all of these side effects as we had these experiences with our patients. And I think you brought up a really important point, which is in medical school, in residency, we didn't talk about pharmacology. I had that background from my pharmacology background as a pharmacist, but most people did not learn about pharmacokinetics, pharmacodynamics. They didn't understand that. And so they based their decisions on their clinical experience, often on habit, and that still continues now.
I would say it's more now. I teach in medicine, I teach in pharmacy, and I'm finding that the pharmacology curriculum is reducing in medicine. In some medical schools, pharmacology is not a major component of their training, and I find that to be very sad. And backing up a little bit, you're talking about side effects of medications in clinical experience, and this again is the beauty of SwitchRx. It's not just about switching. There's a lot of information there on side effects of the medications. So it's not just about switching a medication from one to another, although that's our main emphasis for sure, but there's much more information around the pharmacokinetics, the adverse drug reactions, and also drug-drug interactions.
Special populations, and also in combining. So what we're doing now, which I'm so excited about, is adding disorders. You and I have been extremely busy. So to have almost 140,000 users, 1,500 to 2,000 switches every day, clinicians across the spectrum. So we've got psychiatrists, family doctors, nurse practitioners, pharmacists, all across the spectrum using this. And now we're expanding the disorders that we cover. We're adding ADHD. We're adding bipolar. And of course, so much of what we do in bipolar is not switching, it's combining. We have obesity there. So we're really trying to expand the value of SwitchRx and thinking about not just, okay, how do we switch this, but all the things you need to think about or the questions that you have as you're doing that in a manner you can trust. Because we're not using AI, we're using your brain, my brain, and the empirical research that's out there.
You said so many things, so many things I want to address there, but you're right. We don't use AI. Every switch is based on our understanding of the pharmacology, the pharmacokinetics, the pharmacodynamics, but also clinical experience. It's about reading a lot of papers. So every switch is an individual switch, and I'll use an example of antipsychotics where you are dealing with so many receptors that these medications work on that you're looking from the antipsychotic that you're stopping to the one you're starting. If there's a mismatch in affinity between these receptors, we need to figure out what does that mean clinically, or what could it mean clinically. I talk to a lot of nurse practitioners, and some of them are in remote communities. They don't have access to a psychiatrist, but they have access to SwitchRx. And they use SwitchRx, and they thank us for SwitchRx. And without SwitchRx, I think it would be more difficult to help their patients.
It was one of the greatest compliments, I would say, with the nurse practitioner who was working on another program with me. And she said, I wouldn't have gotten through my nurse practitioner training as a psychiatric nurse practitioner without SwitchRx. Our entire group with me as we went through, it was our touchstone for these medications. It was where we went to be confident about what we were doing. So one of the things I love that you do, Ric, is we ask people to give feedback. When we add new drugs, most of these I have a lot of experience with, but not all of them. Sometimes we add ones we know are coming, for instance. And anytime anyone writes and gives you feedback, you explore it, you get back to them, and we make changes.
I think that's one of the strengths of SwitchRx is that we do have that feedback component. I have had some cases where we didn't actually have that particular switch on the site that somebody wanted, so I developed a switch for them. One of the things I'm most happy about the website, it's free to use. And that was always our most important. One of the most important criteria of the website is it has to be free to the users and it has to be accessible. And it is. And we've expanded from, Canada to now we have a large user base in the US, and that's growing.
We actually have an international user base, Ric. So our largest area of growth is in the US, but we have people across Canada, across US, and around the world using SwitchRx. We want to keep it free. And that, as you said, this has been really important to us that anyone who wants this information can access it. We will need some support to be able to continue to build this and allow it to be accessible, hopefully, eventually to be able to translate it. But what we're going to do is work with partners so that it's very clear that you and I are the same people. We don't sell anybody's drug. What we want people to do is to use these drugs and become confident prescribers so that patient outcomes are better.
I think you just said the most important thing, patient outcomes, and that's what it's all about, is improving patient outcomes.
We are at our core trying to talk to clinicians and the reality of clinicians. What do they need to do in their practice to help their patients to get better? So confident, rational prescribing to improve patient outcomes. Really, that's always at our core.
With a platform like SwitchRx, I think it can go in many different directions.
I know that we have a really large user base that is pharmacists. Why do pharmacists find SwitchRx useful?
I think there's a couple of reasons. One, I'm a professor in pharmacy, and so I go in and I teach about psychotropic medications. And by the time we get to tutorials, they all know about SwitchRx, not from me, but from actually some of the other professors at the faculty. I get a chuckle. Sometimes I go into a pharmacy, and I love going into pharmacies because most of the pharmacists in Vancouver, I've taught them. And so I go and they know about SwitchRx. But even outside of British Columbia, I can go to a pharmacy. I was in Nova Scotia last year. I went into a pharmacy. I said, do you know SwitchRx? He said, of course we know SwitchRx and we use it all the time. So it's very validating that this tool is being used. And I think pharmacists use it quite a bit, maybe because physicians are asking them, listen, this is going to be how this medication I want to use. Can you help me with the switch? And maybe the pharmacists, sometimes they have a little bit more time and they say, yeah, we got this resource called SwitchRx and they use it. But yeah, we have a large user base of pharmacists.
I think they've been our greatest champions. And also, family doctors, nurse practitioners have so little time. So they're saying, you're not happy with this drug, let's switch to this drug. The patient goes in, the pharmacist says, hey, what's happening? You were on this, now you're on that. How are you going to do that? Well, they just said to stop this and start that. That this is a resource for the pharmacist to be able to help them to make sure that transition goes smoothly. So I think pharmacists are amongst the most trusted of healthcare professionals. Patients really rely on them to help to manage these kinds of complicated situations when they're switching, and having that tool so that they're really confident in being able to advise on that switch. I think this is what has drawn pharmacists in for so long.
I just had a flashback. And that flashback was in the day where physicians would say, we're stopping this antidepressant today and we're starting this antidepressant tomorrow, or antipsychotic. And I would have conversations with physicians and saying, perhaps that's not the most kind way of doing it. But it was the way they had always done it. And if I think back now, since 2011, since SwitchRx, how that has changed. And I think switching has really changed because of SwitchRx. And not only that makes sense from a pharmacokinetic, pharmacological, pharmacodynamic approach, but boy, our patients appreciate that so much because it's a much gentler way of switching between medications rather than stopping and starting.
I think it gives physicians, pharmacists, nurse practitioners permission, confidence. And, we always talk about, we want empirically based research. We want to be able to know where this data comes from. What happens if you don't have the data? What if the studies aren't done? Then you do what we did, which is say, how does this drug work? What is the mechanism of action? What receptors does it touch? And then this new drug that you want to start, what does it look like? And what happens when those two come together? So what we did was we took the science and we demonstrated, I think, very thoughtfully. We took a lot of time to try to understand not just the clinical experience that I have, but your deep pharmacological knowledge. And it made sense to clinicians. We were able to show them something that they could use every day.
Well, that's the secret sauce, isn't it? Because when you think about it, there are some manuscripts out there on switching strategies, but they're very, very general. They're based on class of medications, not individual medications. And again, with your clinical knowledge, experience, my scientific background, we can come up with a recipe, but it takes time to bake these recipes because it's individual switches, individual switches, individual switches. But that's the secret sauce is, again, I think, our combination of knowledge, of clinical knowledge and scientific knowledge.
So one of the things that I'm so excited about is that you can use the new SwitchRx platform on your phone, which you could do before, but now it's a much faster experience. It's much more user-friendly. It's easier to navigate, far fewer clicks. And I had no idea how annoying people find clicks, but we really did try to focus on how do you get from your question to your answer as quickly as possible. And whether you're using it on your computer or on your phone, the experience is, I think, much easier, much more quick to be able to get to that answer.
And I hope our users will be very honest with us and to give us feedback. to say, you got it, you nailed it, or you didn't quite nail it, but this is what we would like to see you do next, or how we can improve it. Because it really is, we want to make it very user-friendly so people do use it, so again, to improve patient outcomes.
So we have a new platform. It's going to look really different to people, and it's looked the same for a very long time, 15 years. And we're going to find that there are changes that people aren't particularly thrilled about. Please, we want to hear about them. We want you to tell us what works and what doesn't so that we can address that, because it's new for us too. It's a new platform for us. We've looked at everything again. Every drug has been reconsidered. But if there's something that isn't working, or there's some clinical tidbit that's missing, or an understanding that you have that you might want to share, we really want to hear about it. So in a nutshell, what is SwitchRx? SwitchRx is trying to help to support confident, rational prescribing to improve patient outcomes. And you don't improve patient outcomes by using treatments that we should no longer be using. Ric, you and I have worked together for a very long time. And so I know exactly who you are and what you do. But can you just talk a little bit about your background? Talk about your background and what brought you to SwitchRx?
Absolutely. I was a pharmacist. So I graduated from pharmacy school, University of Manitoba. After I did that, I worked as a clinician at St. Boniface Hospital in Winnipeg. Decided to go back, did my master's degree. Then I moved to Vancouver, did a PhD in medicinal chemistry. After that, my professor said, you shouldn't be working in chemistry with test tubes. You should work with people. So I did my doctor of pharmacy. And after that, I did a residency in psychopharmacology at Riverview Hospital. And my preceptor at the time was amazing. And she said to me, what is it you want to learn? And I was honest with her. I said, I have no idea how these medications work, because at that time, again, psychiatrists were prescribing 2 of this, 2 of that, 2 of this, and I just couldn't figure it out. And so my residency was all about learning psychopharmacology and receptor kinetics and dynamics.
I can tell you that, to me, you are a mesmerizing resource. The depth of your knowledge on how these receptors work, how drugs work together, and how that would have implications for a patient is stunning to me, and such a joy to get to work with you and to experience that knowledge. Very frequently we're together, and I just learn from you every single time that we're together.
I am so happy to be doing what I'm doing. I don't think I could do what you do as a clinician, talking to patients. I need to talk to clinicians. I need to talk about science. I need to talk about receptors. I need to talk about neural pathways. And I think this is why I enjoy working with you and talking with you, because you have that pharmacy background. You have the pharmacology background. You understand receptors. That's what I want to do. That's what I am doing. That's why my career has been actually very fulfilling. I also forgot to mention, after I finished all my schooling, so right now I currently am a clinical professor in the Department of Psychiatry.
Very good. So you know that I went to pharmacy school at Dalhousie, and I enjoyed it. But to be honest, I think I always wanted to go into medicine. I don't think I had wicked imposter syndrome, to be honest. And so I didn't think I'd ever get accepted. Got into medical school, loved it, loved everything I did. Honestly, delivering babies and being in surgery, I could have done anything. But for some strange reason, I decided to do pediatrics and really did not enjoy that experience, mostly because of parents. But then I became one. And then I went into adult psychiatry. And I think, if I'm honest, all the way through medical school, it was psychiatry rotations that were the most interesting to me. I was blown away by these individuals who are living with these challenges and their experiences. And so when I was really honest with myself, it was where my heart was. So I did my residency in psychiatry. I moved out here. I've worked in many different areas in schizophrenia. I did a lot of PTSD with the Canadian military. And then I decided that I wanted to work in technology and really try to support family docs, nurse practitioners, community psychiatrists to be able to provide the standard of care in psychiatry. So I really focused on my technology rapids, as well as continuing to work on SwitchRx, on education. I still have a small clinical practice, and I love seeing my patients, but trying to expand and provide really excellent care in the community in psychiatry is really important. This is a highly stigmatized area still. And the stigma of mental illness doesn't just live sort of out there with some groups of people, it lives in medicine. So it's a constant battle, really, to say, this is important. This affects all of your health. Mental health is health. And so being an educator like you is the most fulfilling part, I think, of what I do.
Interesting you say it was your passion. You found your passion. It was psychiatry, and you kind of knew it all along. Psychopharm was not my passion. When I did my rotation in psychiatry, I remember literally it was the only rotation I did in my PharmD program that I looked at the medication list that the patients were on, and I just couldn't figure it out. And I actually broke out in a cold sweat. I couldn't figure it out. It became my challenge. And it became my challenge, and I ended up doing something that it was not my passion, but it became my challenge, and now it has become my passion for sure. But you also mentioned stigma. When I started teaching at the university in 1997, pharmacy students, I would say, how many individuals in the class have diabetes? Oh, some hands go up. How many individuals, and I go down the list, asthma. And they say, how many people have a mental health issue? And there would be laughter, there'd be giggle. There was this very uncomfortableness. And that changed over the years because I would do that the first day. And then it changed to the point with even a year or two ago, hands would go up, oh yeah, my brother has this, or my sister has this, or I have. It really has changed over time. So stigma is a big part. Still we see it.
Still a big part, but I'm really happy that you do that, because if it doesn't change in medicine, if it doesn't change amongst caregivers, it really has a profound impact on patients. They do feel othered. And it's okay if you come in and your sugars are high, or you come in and your blood pressure is out of control. But if you come in and you're out of control, your brain is out of control, lots of my colleagues are not comfortable with managing that. And it is such a core part in any community practice that you are confidently able to help manage someone who's dealing with depression, bipolar, psychotic symptoms, ADHD.
I brought in a patient, an individual with schizophrenia into the classroom. And she said something just so profound to the student. She said, when you break your leg, your brain tells you your leg is broken. But when your brain is broken, your brain can't tell you that it's broken. And that still resonates with me. And also, too, the language, schizophrenic. No, we have people with schizophrenia. Yeah. We don't have schizophrenics. I know we're kind of moving away from SwitchRx, but, I think this is just important, to talk about these things.
I do, too. Yeah. And, those profound things that you're told. The number of people I saw when I was treating PTSD as a civilian in the Canadian military was, I wish to God my leg had been blown off, because people would understand that. They'd understand that pain. And also the people who, I learned so much from my patients, like more than anything, the experience of my patients with medications, but just with their journey through their illness, and having people who had PTSD through horrifying things happening to them. And for them, as they started to get better, to say to me, I wouldn't have asked to be blown up, or I wouldn't have asked to be sexually assaulted. But in some ways, I'm glad it happened, because this is now my life. This is what I gained from that. And from that, I learned that out of absolutely horrible things, good things can come. And those are the kind of experiences that you have with patients that give you their trust, that help to become your rudder. They help other people, because you become, I think, you have a deeper understanding of their journey, and it also gives you a deeper empathy for their experience.
For sure. And I think this is where you have that connection with the patients, that you get that satisfaction because you deal face-to-face with patients. I don't. I deal with psychiatrists, with nurse practitioners, giving them consults, and I do this on a weekly basis across the country. My reward comes when they call me back and say, Ric, thank you. You helped my patient. So I don't get that reward from the patient, but I get that reward from the clinician that says, thank you for helping. That's kind of my motto. Doctor, let me help you help your patient. That's what I'm about.
I think that's what SwitchRx is all about.
Yeah.
We want to help clinicians to help their patients. And we both have very different experiences, some overlap there. But I think that's why we work so well together, because we bring, a different ingredient in that makes up that secret sauce that is SwitchRx.
So back to the first phone call you made. Ric, what are you doing for the next 20 years?
I even remember the coach we were sitting on. I don't know where it was, it was at some hotel where there was a big conference, and we were sitting in this basement area, and I said, "Hey, Ric, I got this issue with aripiprazole, and people are saying all these things, and I don't think they're correct. It's not my experience." And the other thing, Ric, and I remember talking to you about this ages ago, people who were on older agents like risperidone, and they're trying out aripiprazole, and their patients suddenly have tardive dyskinesia. Or that's what they think it is, but it's just a sudden onset of dyskinesia. What's going on? Well, it's obviously the aripiprazole is a disaster. No. It's stopping the risperidone. This is what's provoking it. And how do you stop it and start aripiprazole without provoking terrible dyskinesias that make it obvious for the patient that there's something wrong with them? And so they're very uncomfortable with that. Those are the kind of things that I think we've really made a difference in with SwitchRx over the years.
I had a very similar consult, very, very similar risperidone switching over to aripiprazole. All of a sudden, some withdrawal dyskinesias, and I got a call from the physician saying, "We've got tardive dyskinesia." I said, "Please don't write that in the chart, because I think it's just a withdrawal dyskinesia." So again, understanding the receptor profile and the kinetics and the pharmacology, and we translate that. We put that into SwitchRx in a much simpler way so people can find this information.
Absolutely.